And I will send this out to everybody afterwards. Oh boy. I thought I'd start things off slow. Good on you guys who recognized gentamicin. I did that last year and people were alarmed. Okay, now to the real. Okay, so we have a Staph aureus infection. Oh, I had a great meme for this one and forgot to attach it. Let me see if I can post it in the chat. All right, good job, you guys. So does anybody want to say why one or as many as you'd like to say of the other ones aren't good empiric choices for Staph aureus? This is a tough question because it's pretty applied.
I just know imipenem, isn't that one that's reserved for like drug resistant?
Yeah, so even if this one would be effective against Staph aureus, we certainly wouldn't want to use it in an empiric context. Nice one, Ashley. Does anybody remember the spectrum for aminoglycosides?
Is it only like gram positive aerobes with some select negative?
So you're super close there. You're exactly right. It's only aerobes. That's a really big thing to remember. So aminoglycosides, they have to be taken into the cell to act, because remember, they're inhibiting protein synthesis. And for them to be taken into cells, they require oxygen. It's just an aside. But they only target gram negatives for the most part. But yeah, you were super close. And then metronidazole, it's also got a very specific spectrum, if anybody recalls that one.
It's only anaerobes for metro.
Yeah, exactly, anaerobes. So Staphylococcus is going to be a gram positive, and then it's going to be an aerobe. All right, because you find it on your skin and whatnot. So, and it can get a little bit dicey when you get into like facultative aerobe and anaerobe, but I wouldn't worry too much. They're not going to quiz you too much on agents. They're not going to like name random bacteria. The ones that she really emphasized are the ones that she might bring up. Oh no. So which of these would you not want to inject into a horse? And that's your poor old horse that is always going to be injecting into. I don't know if she's in here. Last year, I had Andrew Sacolaris for this question, and he somewhat appreciated it. Nice, really good job, you guys. So I meant to change it where oxytetracycline, it can be given safely IV, but you have to dilute it and you have to give it slowly. So you guys were totally on it for that one. And I meant to actually change that answer choice. But it can be given safely IV, but it definitely can have some risks associated. So you guys were on it. That probably should have been a right answer. But procaine penicillin, I know last year, I listened to the lectures last year because Dr. Beasley's new. I haven't re-listened to them, but last year she made a big deal about that.
Yeah, she told us a horrific story about it. So
yeah, geez. And then potassium penicillin, the large animal people, you guys know that they give K-Pen all the time. They do give that slowly over like 5 minutes or so, but it is safe to give. So good on you guys who said Oxytet. You guys are probably right on that one too. All right. Okay, dig up your derm knowledge. Pemphigus foliaceus. It's going to be an immune-mediated disease. And it was pretty considerate of this patient to self-prescribe and save you the trouble. this is something that you just know you're going to get asked this on the exam. Like Dr. Ward was pretty transparent about that. Knowing those doses is important, and that's something that on clinics, they totally expect you to know that as well. I've been asked that multiple times in clinics. So you just got to throw those in your brain, those doses. I think they kind of make sense when you think through them. But does anybody remember our physiologic dose? Which of these 4 answer choices would be that?
0.2 to 0.4.
Exactly. So if you have to taper an animal super fast, like they're having really bad reactions to steroids, if you have to drop them right away, you would at least leave them with like 0.25 or so to make sure they have enough for physiologic function and don't go into straight Addisons. And then what's our anti-inflammatory?
0.5 to 0.1, or sorry, 0.5 to 1.
Exactly. So it's kind of like just a little bit higher. It makes sense. We're knocking back a lot of those cytokines. And then we need a really high dose if we're like literally causing lymphotoxic effects and causing our lymphocytes to stop functioning and affecting our neutrophils. So I think when you logically think through it, you kind of have to do a little bit less memorizing. And those are the really important ones to remember. And then there's like 1 mg per kg for lymphoma, and I don't remember the other one, but you guys should. All right. This is also super important. And this picture was more relevant last year. Nice. Awesome, you guys. So you got this down. They will 100% ask you this in clinics. And on the other day, I got a referral on internal medicine, and they were giving dexamethasone at 0.5 mg per kg twice per day, which ends up being like 10 mg per kg per day of pred. And the IM clinicians were like, oh my God. Ah. So make sure you remember this. It's easy to forget. And it's important. All right. All right. So this is something where when you're using a high immunosuppressive dose, you really want to taper that slowly. So I just had an immune-mediated thrombocytopenia on clinics, and we were going to wait a full month and then see if they were fully controlled. And then after that, we were going to knock it down 25% per month for the next 4 months. So when you're at these really high immunosuppressive doses, you need to kind of like be patient and slowly take them off. And I think she makes a big point of that. I think she says 6 months in the lecture. All right, but those over weeks, I can totally see why you guys thought that. And it depends on the duration of how long you've been giving them that. This is a patient I saw this week, Cora. She's cushingoid. You can see her pot belly, and she actually had calcinosis cutis on her back, and she was panting all the time. And literally, I would stand outside her cage holding her water bowl, and I could like move it, and her eyes would follow it all the way. And she cannonballed like 3 bowls of water. I just like, as soon as I put it in, she would just chug them. So it can be really miserable. So it's definitely a great thing to treat. And there's some pretty severe sequelae of it. So it's definitely a pretty serious disease that you'll probably see in clinics. And if not in clinics, definitely in practice if you're GP. Does anybody know what that white spot is? It's a little implant thing.
So for checking insulin?
Yeah, so it's for planning for insulin, but it's a Libre like continuous glucose monitor, and it checks their blood glucose for 2 weeks. So it's like a 2-week blood glucose curve. And when you're cushingoid, you're super insulin resistant. So this animal was concurrently both diabetic and cushingoid, which gets pretty complicated. Does anybody know why cushingoid dogs get pot bellies like this? Did they tell you that in class?
Don't their abdominal muscles, sorry.
Oh, go ahead.
Don't their abdominal muscles get like wasted away
Yeah, exactly. So your rectus abdominis and some of the other abdominal muscles really atrophy, and then you're just kind of letting it all hang down. And they can also get some hepatomegaly as well, like a vacuolar hepatopathy, since you're mobilizing tons of lipids with your corticosteroids. So sometimes thinking about why a patient looks that way and then correlating that with the mechanisms of the disease can be really helpful for remembering. And it helps for remembering the side effects of steroids as well. Faith, good on you. Turtle, nice. Okay, just mechanism of action. You just got to chug these. I gave you a little bit of a graphic as a hint. This is something where pharmacology, the mechanism of action is just such low-hanging fruit that you just got to flashcard them or have them in your brain. Don't walk into the test not knowing a mechanism of action for a drug that they spent at least a decent little bit of time on. Nice. Good job, you guys. So it blocks an enzyme that converts one of the precursor steroid molecules into cortisol. Good job. And some of these other ones, which one straight up kills your adrenal cells? Does anybody remember?
Miditan?
Yeah, exactly. That one's pretty scary to use, and they don't really reach for that in practice unless the animal doesn't do well on trilostane. Does anybody remember which one's the dopamine receptor agonist?
Paraglide.
Yeah, exactly. And we use that in horses because they get that PPID. That's a different mechanism where the dopamine is what's controlling the release of ACTH, I believe, or CRH. And then GnRH superagonist. We've got some exotics people in here that have got to know this one.
Lupron.
Yeah, exactly. So they have a different type of hyperadrenocorticism, and it's much more sex hormone related than just cortisol. Good job. If you go into exotics, you will 100% see ferrets with that. Like, that is a fact. Oh man, Dr. Ward actually really kind of quizzed us pretty good on side effects, I remember. So remembering the top 1 or 2 side effects, especially really severe ones, is good to do for her. That was something that blindsided some people in my class, I remember. Oh man, so that was confusing. So mitotane, while it dose dependently causes your adrenal cells to necrose or apoptose, but one of the I should have said idiosyncratic adrenal necrosis, but one of the non-dose dependent side effects is with trilostane, they can start to have adrenal necrosis, and it's something that you've got to look out for because that's what can cause them to become permanently Addisonian. So I totally confused you guys by talking about mitotane right before that, but you guys were on it. Definitely, you can see how professors put questions out there that do terribly, and you're like, how did this happen? Some pretty good hints in the past couple of discussions. This poor ferret. Nice. Good job, you guys. I think you guys have that one down. Okay. So which of these drugs would you be concerned about? Or which of these would you feel safe using in a patient with renal insufficiency? That's what I was getting at. This is kind of a tough one. It's pretty important to know when a drug is cleared by the kidneys or has nephrotoxic effects, because there are a lot of animals that have kidney compromise. Yeah, you guys will know that by tomorrow. And that was a tough one because she didn't emphasize it as much with like polymyxin B. But amikacin, definitely don't want to use that one. Does anybody remember what class that is?
Aminoglycoside.
Yeah, so aminoglycosides, that's a very strict contraindication where that can cause some really severe nephrotoxicity. So you wouldn't want to use that in a hypovolemic animal that's like hypoperfusing their kidneys or that already has renal disease. And then tetracyclines, you have to be really careful with those. Doxycycline's a little bit safer, but she makes a point about how tetracyclines, they're cleared through the kidneys, so you have to be careful. And then polymyxin B, she also made that claim. And then metronidazole is a lot safer. I think it's more through your liver, which makes sense because it's really lipophilic, if you guys remember, and really good at going into these lipophilic areas and getting anaerobes. All right. I don't remember if I fixed the answer on this one, but we'll have a good discussion. Does anybody know what this picture's from?
Is it very power musical or something like that? Kind of looks.
That's a good guess. That's cool. There was one person last year. It's Flight of the Conchords. It's like a New Zealand comedy show, but they do a fundraiser for epilepsy in dogs because they're trying to impress this girl whose dog has epilepsy. It's pretty hilarious.
Here's an example of a ferret with an implant.
All right. Oh no, this is the mark of a terrible question. But so pretty much we suspect a meningitis with anaerobes. So I think metronidazole would have been a pretty good choice. I meant to have that also be an answer. But clavamox, if you remember, your penicillins, your beta-lactams have pretty good anaerobe activity. And then enrofloxacin. Does anybody want to say why they were kind of more thinking enrofloxacin? I guess it's broad spectrum, so it could have been good. Gosh, yeah. See, this just wasn't that great of a question, but just kind of knowing the spectrums of what covers anaerobes well, or metronidazole and clavamox is a really good one because it's just really good at getting in there when there's inflammation. And then
Fred, do all of these cross the blood-brain barrier, or is it just the amoxicillin beta-lactams?
So actually metronidazole would be better at crossing the blood-brain barrier, but when there's meningitis, one of the points I wanted to make is when you have meningitis, it breaks down the blood-brain barrier. So that's why a hydrophilic drug like clavamox can do really well to get in there. So this was a really tough question. She won't ask a question this tough, but just kind of knowing the spectrums well, like which ones affect anaerobes, and that was a point.
Is the gentamicin like neurotoxic? Like that would be another good reason not to use it.
Oh, that's a really good point. So definitely not something we worry about, neurotoxicity. With gentamicin, does anybody want to say why that would be a bad choice in this case? It's an aminoglycoside. Does anybody remember its spectrum?
You said it was for aerobes.
Yeah, exactly. So it's only aerobes. Aminoglycosides require oxygen to get taken into cells where they can act. So they can only do that in aerobic environments where aerobes live. All right. All right, this one's really confusing, so think about it for a second. But it's your pet streptococcus, so you don't want to hurt them. So you don't want to use something that kills strep. This was just kind of a fun question. That's more fun for me than probably you guys, but I thought it was funny. Okay, So enrofloxacin, she mentioned in class, has a bad spectrum of activity for streptococcus and some of the other like gram positives that are common, but especially strep. She made a big point of that last year. I'm not sure if she did this year. That was nice of you guys to treat your pet streptococcus for its condition. I should have given more time. Okay, this one definitely, it's a good question. You got to know this. This is an important consideration. So your tick-borne rickettsial diseases, they're kind of these funky organisms. Which one's going to be your best for getting those? All right, good job, you guys. So the tetracyclines, and doxycycline is a very common one to use, have a good activity level against these odd, kind of like bizarre bacteria, like your tick-bornes and whatnot, and like mycoplasma. So that is important to note. That's just a really like low-hanging question she could ask. And also we use doxycycline all the time. Like anytime an animal has thrombocytopenia, they're like, well, you might as well give it doxy. Okay, so which of these drugs is concentration dependent? Where what we care about is getting a really high concentration. We don't need a super sustained one. And I gave you guys this nice graphic. Nice, good job. So I think it's helpful to remember that pretty much aminoglycosides are just about your only one that's truly concentration dependent. Where fluoroquinolones, they used to be thought of that way, but now they're kind of more thought about as area under the curve, as just having this kind of like sort of time dependent and concentration dependent mix. And then there's only a few that are truly time dependent. So if she made a big point about that for that group, I would definitely remember that. But just being smart and being like, well, I know the only one that's concentration dependent is fluoroquinolones. So then I can instantly narrow it down to one or two. And then you can kind of better guess from there if you haven't memorized all of those characteristics. Kind of like there's not that many drugs that are really good against anaerobes. So knowing those kind of clues you in. Just kind of being strategic with your learning. Good job, Ashley. Okay. So with osteomyelitis, we need a drug that's relatively lipophilic and able to get into these hard to penetrate areas. I don't know if you guys remember, but penicillin, does anybody remember its solubility? Okay, good job, you guys. So for osteomyelitis, we're going to need a drug that's lipophilic, can get into this closed off, kind of encased area, and that has good penetration. So your penicillins and the imipenem and vancomycin, which are kind of fellow beta-lactams, they're going to be more hydrophilic, and they just won't be able to get as great of penetration. So clindamycin's the best pick for this one. And I think she kind of emphasizes that as one of the best uses for lincosamides, which clindamycin is the most commonly used of by far. We put a dog on clindamycin the other week in clinics because it had like a coccidial organism that was insisting, or that had a risk of insisting in its muscles and stuff. And we needed really good penetration. Okay, so you as a human being are trying to shut down your myeloid progenitor cells. So which of these has the risk of that to humans? They made a big point of this in class, and they will when you use it in clinics. They make you wear gloves and stuff. Nice, good job. So it causes an aplastic anemia. And actually in other countries like India, they actually still use chloramphenicol because there's a very low risk of it causing that. But with us, since it's such a severe consequence, we just really take an abundance of caution. So that's something that's like low-hanging fruit. Like they love to ask you about stuff like that, like really severe potential side effects of using it. Okay, so which of these signalments is the most consistent with, or most commonly getting hyperthyroidism, and what's the most common mechanism? So this is something she went into a decent amount of time of. And this is something that will come up in clinics as well. Nice, good job, you guys. So the most common cause by far of feline hyperthyroidism, and hyperthyroidism is way, way more common in cats than dogs. Like you see it all the time in cats and you almost never see it in dogs, is a benign thyroid hyperplasia, where it's much less common to have pituitary disease causing it. So a lot of times you can palpate and feel like a thyroid slip, where you palpate along their trachea and you feel this like slip of tissue go through your fingers because their thyroids are just kind of enlarging. All right. So what's a potential risk of I-131 treatment? Good job, you guys. So the biggest risk is overdoing it and giving too much of the radioactive iodine, and then you shut down too much of their thyroid gland, and it causes them to be iatrogenically hypothyroid and need thyroid supplementation for the rest of their life. So that's something you always warn clients about when they're going through this. And at UGA, we just started doing I-131 treatment again. I had a cat a couple weeks ago that got it, but it's totally something you have to warn them. Does anybody remember which drug can cause facial excoriations and hepatotoxicity?
Is it methimazole?
Yeah, methimazole. So methimazole is the most commonly used drug to treat hyperthyroidism, but it can cause facial excoriations, where they just start to get these kind of wounds on their face spontaneously, or hepatotoxicity. So my cat a couple weeks ago that we did the I-131 treatment on, it was on methimazole for about a year and it was well controlled. And then you do regular blood screenings and it had pretty severely elevated liver enzymes. So we had to take it off of methimazole, and that's why we did I-131 for it, which is pretty expensive, but it can pay off in the long term rather than medicating them for life. So those are things to worry about with methimazole. And like I said, Dr. Ward, I remember her asking about those side effects just because she's a clinician and those are things you always think about and warn clients of. So she thinks that's really important. And it is. Okay. Pretty crazy that Thomas Addison had a dog with Addison's. Does anybody remember why these dogs tend to get hyponatremia and hyperkalemia?
They don't have enough aldosterone.
Yeah, exactly. They don't have enough mineralocorticoid activity, with aldosterone being the main one. All right. Good job, you guys. Does somebody want to say why they picked that over the 0.5 mg per kg pred plus DOCP?
I think it's because you want to put them on a physiologic dose. Well, you want to give them DOCP for the mineralocorticoid, and then you also want to give them the physiologic dose of the glucocorticoid.
Yeah, exactly. Perfect. So 0.5, that's our anti-inflammatory dose. So that would be overdoing it. We just need to give them a physiologic supply of cortisol. And then mitotane, everybody remembers what's our mitotane treating?
Cushing's.
Hyperthyroid corticism.
Yeah, exactly. It straight up kills your adrenal cells, which was confusing in that previous question. All right, Dad has taken the lead. Okay, this is confusing. Now Thomas Addison has a dog with something else going on. Not Addison's this time, even though it's Thomas Addison. It's confusing. Also, Thomas Addison's the dude who discovered Addison's, if anybody hadn't. So what's the most common cause of this condition that is described? And 2 of these answers could be right. All right, good job, you guys. A couple of you caught on. You totally, if somebody gave this dog too much I-131, that totally could cause hypothyroidism. That usually doesn't happen. But the most common cause is going to be immune-mediated destruction of the thyroid gland. So just kind of that's the most common reason by a good margin for why dogs get this. And hypothyroidism is something we see much more commonly in dogs than cats. So that's the most important thing to remember, that hypothyroidism, much more common dogs, hyperthyroidism, much more common cats. And then she went into a decent amount of detail about the breakdowns of what the most common causes are. So it could be worthwhile to have those kind of in your brain. All right. So we less commonly see pituitary dysfunction for this, but you could. It's just a lot less common. Oh no. So your mare has a broken heart, and it's actually just cardiac toxicity.
It's obviously the stallion next door.
Yeah, it could have been. And is there a horse person here who can say if horses actually cry or if this is just sweat and it's like a misinterpreted photograph? Oh, so for this one, monensin, that's the most likely. Does somebody know something about florfenicol that I don't know? Did you talk about? I thought that one was safe to use in horses. But monensin, that's going to be an antimicrobial that's used more in cattle. And if it's put in their feed. And if a horse eats feed with monensin in it, they can get cardiac toxicity. That's a good Navli question. Also, Veronica, I just saw that you got Freestyle Libre. That's awesome. I didn't see that at the time. But yeah, monensin, that's just a really common toxicity. Totally something she could ask. That's kind of the most important thing to know about monensin for this exam. and that's in horses. It doesn't cause that in cows. It's a common feed additive. Okay. So which of these has a different mechanism of action? Nice. Good job, you guys. So if you guys remember, does somebody want to say what group of antibiotics vancomycin is? It's kind of in its own thing, but it's part of a larger overarching group.
Glycopeptides or something like that.
Yeah, it's still kind of grouped with the beta lactams though. It's got like a similar mechanism of action of targeting the cell wall. And then clavamox. Does anybody want to say our two ingredients of clavamox?
Amoxicillin and clavulanic acid.
Yeah, exactly. So we have amoxicillin, so it's a penicillin, a beta lactam. Cephalexin is a beta lactam. So those both target our cell wall. And then, does anybody know what generation of cephalosporins cephalexin is?
First,
Yeah, first generation. So that's a really helpful tip, is that when it's like FA or PHA, those are your first generations. Anytime it's like Pha in the name, so cephalexin or cefazolin, those are your first generations, and they have a more narrow spectrum than our third generations. And there aren't any second generations that we use for some reason. So those kind of small tips that help you group different groups of drugs are really helpful. Okay, what diet should we feed our diabetic dog? Awesome. Good job, you guys. So we definitely don't want soluble fiber, like our digestible carbohydrates, because we're trying to help with their glucose regulation. And then the high insoluble fiber can help with gut transit, and I think just kind of decrease the amount of total glucose they're getting in as more of it's moving through their digestive tract faster. And then if this was a cat, what would we want to feed them?
Low carb.
Barb.
Yeah, low carb. So the high insoluble fibers aren't as helpful in cats. It's a lot more important for dogs with diabetes. And then somebody want to say what's going on with this dog here?
Redhead.
What's that?
Does he have redhead?
So it's very, very similar result, but when you have diabetes, you can also see muscle wasting. Because as you remember, insulin's a very anabolic hormone. So when it can't act properly and cause proper development of muscle and you can't get enough glucose into your muscles, you can see muscle wasting with dogs and cats that are just diabetic too. So that's where it can be a bit confusing, because Cushing and diabetic dogs and cats can have muscle wasting, PUPD, be polyphagic, and you have to kind of pick up on subtleties.
can you explain why you would not do no carb in dogs as well?
So it's Dr. Ward just kind of mentioned that these are the best diets. My understanding is, and I don't know the full nuances that an internist like her does, but you're doing low insoluble fiber or low soluble fiber. So we don't want very digestible carbohydrates that they can just pull in a lot of glucose from. And we want high insoluble fiber because it increases or it speeds up our gut transit time. So it makes food go through the GI tract faster, and then there's less time for microbes to break it apart and free up glucose to go in and for glucose to be absorbed. So it just kind of makes it like a steadier, smoother, less glucose being absorbed. All right. This is tough. You have two very brilliant people quizzing you. And this is an emergency. The cat's decompensating. You have to do something ASAP. Look at it. It's unconscious. All right. Good job, you guys. So regular insulin or Novolin R, you'll just hear it called regular insulin all the time. But that's going to be the one that's really fast acting. It's short duration. You're not going to send a dog home with regular insulin. But if we're using like an insulin CRI or doing like every other hour intramuscular insulin for an animal that's decompensating and super hyperglycemic, we're going to reach for regular insulin because it's got a very fast onset. So Glargine, Prozac, and Vetsolin, those are going to be more intermediate acting, where those are going to be more feasible options for keeping an animal on them for long term. Did anybody take Latin? Does anybody remember what lente means in Latin?
Oh, in Spanish, or like lento is slow in Spanish.
Yeah, so lente means slow in Latin. So it's slow acting, slow releasing, slow onset. So it's not going to be one that you reach for right away. And then Prozac, kind of the whole point is it's bound up with zinc, so it's kind of precipitated. So it's going to be absorbed much slower too. And Glargine similar. Oh boy. So are these both? There are two insulins that are approved by the FDA. And then are these good choices for a cat, both of them? There are a couple good choices. False. Good job, you guys. Does somebody want to say which of these is FDA approved?
Prozac.
Yeah, exactly. And which one would you not want to use long-term in cats? It's irresponsible to use long-term in cats. Its initials are also the initials of a famous actor.
NPH.
Yeah. So NPH, that's one that we're going to much more commonly use in dogs. And it's really great because it's super cheap. It's really good for big dogs. That dog, Cora, who had the continuous glucose monitor, she was on NPH because she was a bigger dog that needed like a nice cheap insulin. But in cats, it's going to have a really short duration where even twice a day, you're going to have insufficient control because there are going to be periods of the day where they don't have adequate insulin in their system. So you would use Prozac or you would use Vetsolin most commonly in cats. And Vetsolin is the other one. Vetsolin was for a while the only insulin that was FDA approved for animals. And it's specifically for animals. It's a pig insulin. All right. Okay, so this animal has all the signs of hypercalcemia and it's very hypocalcemic. So statistically, what's the most common cause of hypercalcemia in dogs? Good job. So insulin or lymphoma is the most common cause of hypercalcemia in dogs. Does anybody remember the mechanism of that? Have you guys learned that yet? So neoplastic cells and lymphoma very commonly does this. There's some other cancers that do this somewhat commonly. It's called a paraneoplastic effect, but some lymphoma cells will produce parathyroid hormone related peptide, which is this peptide that acts like parathyroid hormone and goes and overstimulates the release of, or the activation of like releasing ionized calcium and all that. So osteolysis, that could be a cause. It's just a lot less common. Cushing's disease does not commonly cause hypercalcemia. The flip side of it, Addison's, is a disease that causes hypercalcemia. I believe that's the second most common cause of hypercalcemia in dogs, but Cushing's, it's not something we commonly see. And then primary hypoparathyroidism, we would see hypocalcemia. Okay. Nice, Ashley, staying in there. So which of these wouldn't be helpful for our hypercalcemic dog? All right, good job, you guys. So corticosteroids actually can help with, or do help with, clearing calcium. So they increase renal excretion of calcium. That's something that Dr. Ward mentioned in class as a potential drug that you could give. And like I just said, with Cushing's disease, we don't commonly see hypercalcemia because having extra steroids in your body actually helps with clearance of calcium. Versus with Addison's, it makes sense that with Addison's, if you don't have enough steroids, you see hypercalcemia. You're clearing less from your kidneys. So that's kind of a connection you can make. IV saline, when we have natriuresis, when we're excreting more sodium in our kidneys, that's going to stimulate more calcium excretion as well. And then furosemide leads to more calcium excretion. Our thiazide diuretics, their mechanism, the way the ion swapping works in the tubules, you end up reabsorbing more calcium from the nephrons. So this is a picture of a bird that was hypercalcemic, and then a vet student didn't pay attention in pharmacology class and gave it thiazide diuretics, and it completely calcified. So that's a cautionary tale. All right. So what would cause a chief cell to release parathyroid hormone? And decrease is DEC is decrease and INC is increase. It's not December and incorporated. Good job, you guys. That's awesome. That was a bit of a tough question. So it's very obvious, or it's somewhat intuitive that when you have a decrease in blood calcium, of course, you'd want to release more parathyroid hormone to increase your ionized calcium again. Does anybody know why, if your blood phosphorus goes up, you release more parathyroid hormone? For me, it's really helpful if you know the mechanism of something. That helps me remember it. Then if you get in the test and you're like, your brain falls out of your head and you're like, oh shit, I just memorized increase or decrease and I'm forgetting. Like, it's helpful if you can think it through and kind of get yourself out of that jam. Anyone? Veronica, you had that great answer earlier about the Libra. To call someone out. So pretty much the most common, or well, I'll restart, but so that's okay. But with phosphorus, when you have phosphorus and phosphates at elevated levels, if you remember, phosphate's going to be binding to calcium. It's going to be binding it and effectively taking it out of circulation because it can't be used for its normal functions anymore. So when you have increased phosphorus, your hyperthyroid or your parathyroid gland is like, oh, there's more phosphorus that's going to be binding the calcium. I need to get ahead of that, and I need to increase the release of this because parathyroid hormone is going to be causing more excretion of phosphorus. So it's getting rid of something that's binding calcium. And this is the mechanism of why you can see pretty severe hypercalcemia with animals that have renal failure, because the most common cause of hyperphosphatemia is going to be because you're not clearing enough from your kidneys. If your GFR is really low, your phosphorus will keep going up, and when your phosphorus goes going up, it's going to keep stimulating your parathyroid gland. So I think that's really cool physiology. And if you're doing exotics, you will get quizzed on vitamin D physiology all the time, because there's tons of exotic animals that have been destroyed by calcium dysregulation, unfortunately. All right. So we don't have dopamine and histamine in our chemoreceptor trigger zone in cats. So which of these would be good? Good job, you guys. What are the two receptors that cats mainly have in their chemoreceptor trigger zone? The two that are most specific to them?
Serotonin, norepinephrine.
Exactly. Nice one, Allie. So exactly. So our cats are going to have serotonin, norepinephrine, and then our dogs have our dopamine and histamine. So if we use an antihistamine like diphenhydramine, which is Benadryl, or acepromazine, which is a dopamine antagonist, then that wouldn't be as helpful in cats. Ondansetron is going to be a lot more helpful in cats because they have serotonin receptors in their chemoreceptor trigger zone. Where do cats not have many serotonin receptors? Does anybody remember this from the lecture? Where dogs do have more?
Is it in the gut?
Yeah, exactly, our viscera. So remember, we have our humoral pathway, which is where your chemoreceptor trigger zone is going to be acting more. And then we have our neural pathway, where your gut is upset. And then you have vagosympathetic afferents coming back to your brain, your vomiting center, and putting their input in. So dogs are going to have a lot more serotonin receptors in their viscera. Nice. So I was just at Brookfield Zoo, and a couple of the tigers actually, and one of the leopards got COVID, and we put them on Zofran, which is ondansetron, because they felt like hot garbage, and they really perked up. And that's because if you think about it, if you're sick, you'll have these kind of inflammatory mediators and whatnot in your bloodstream, more humoral, and so blocking at that chemoreceptor trigger zone can be really helpful for making you feel better. And Zofran is very common to use in people as well that are going through chemotherapy or whatnot. Or if you have a really bad hangover, one of my friends gave me Zofran when I was super hungover, and it helped a lot.
That's
So-
how I remember it. Because serotonin makes you happy, and when you feel like absolute hot garbage, nothing makes you happier than Zofran.
Yeah, there you go. I always think it sounds like a dancing robot, which boosts my serotonin, which is the picture here. So this is a dancing robot. Good job, you guys. So there's a couple reasons why this isn't true. Does anybody want to say one of those reasons?
Is it because it says 5-HT4 antagonist and it should be 5-HT3?
Yeah, nice. So that was a subtle falsity. And then kind of the bigger one is that, so dogs have a lot of serotonin in their viscera, in their actual GI tract and in their vagal afferents. So it's still really helpful for like a dog with gastroenteritis or something. So we use it a lot in clinics at dogs that just don't feel good, like after surgery, because the anesthetic drugs kind of slowed down their GI tract, or they had intestinal surgery. and they just feel crappy and nauseous. Full reach for it a good amount of the time. I don't remember if I have questions on meropitant, but does anybody remember where meropitant acts? Like what different sites?
Oh, it works at the NK1 receptors, isn't it?
Yeah, exactly. So NK1 receptors, neurokinin-1 receptors, and it's preventing the blocking of substance P. That's part of why some people think it has a little bit of visceral analgesic effects. But it's going to be working at both the CRTZ, so both dogs and cats have NK1 at their CRTZ and in their viscera. So that's why meropitant's really nice, like Serenium. That's why vets give it all the time, is because you don't need to say, is this humoral or is this visceral? Because it's at both. So it's a really nice kind of like empiric, this animal's nauseous and I want to help. That said, people probably still overuse it sometimes. Did you guys even talk about famotidine? I know it was towards the end. I wasn't sure if you made it that far.
Yes, we did.
Nice. So when Dr. Uvig gave us this lecture, we were the first year he did it. And at the beginning of class, we were like a couple slides in, and there was that slide on the chemoreceptor trigger zone. And I like to write professor quotes in my notes because I think they're hilarious. And he was like, have you guys ever heard of the chemoreceptor trigger zone? And we were all like, no. And he was like, God damn. He was just like, what do I do? So famotidine is going to be, does anybody know its mechanism?
Histamine antagonist?
Yeah, a histamine antagonist. So it's going to be blocking histamine, and histamine is a humoral mediator that causes increased acid secretion. So that's why sometimes with mast cell tumors or other causes of high histamine, you can see like gastric ulceration just because they produce so much acid. Metoclopramide, that was a bit tricky. It has multiple different places it acts on. But the way that so metoclopramide is a dopamine antagonist. It's one of its most common functions, and that's why it's a good antiemetic in dogs, not in cats, because they don't have the dopamine in their CRTZ. But it still can be helpful in cats because it's a 5-HT4 agonist. And does anybody remember what agonizing 5-HT4 does?
It increases motility.
Yeah. So the most common use of metoclopramide that I've seen, at least in clinics, is going to be for its prokinetic effect. So if you have an animal with ileus in the hospital, or we use it in some exotic species, it's going to be really good for that because it's agonizing 5-HT4, which is confusing, but 5-HT3, that's going to be more for nausea. All right. And then omeprazole and misoprostol, those are correct. So famotidine, it's got a similar function to omeprazole where it's decreasing acid production in the stomach. And omeprazole is actually going to be a lot more potent of an acid suppressant or gastroprotectant. That's what we most commonly call them because it's directly blocking the pump itself rather than something upstream. So if you have a GI ulcer, it's better to use omeprazole or pantoprazole. Ashley, nice. Okay, so what's an anticoagulant that's specifically targeting our platelets? Your client's being very picky. Good job, you guys. Does anybody remember what clopidogrel does? I feel like it's one of the trickier, more involved mechanisms of drugs out there that you
So
guys like in this section.
An antagonist of like the purogenic P2Y12 or something like that. Confusing.
Yeah, exactly like that, actually. Good job. So it's going to be blocking the binding of ADP, which activated platelets release, and they bind to that purine receptor, that P2Y12 receptor, and then the P2Y12 receptor, when it's bound, it causes the glycoprotein 2B and 3A receptor to be expressed, which then binds to fibrin. So that's really involved, but just kind of remembering for the most part. Maybe remember it binds to purine or it antagonizes purine receptors, but just remember it acts on platelets themselves, not the clotting cascade. That's the most important thing to remember. And we use this quite commonly, actually, or not quite commonly, but totally in animals with thrombi. Like we've had a couple arterial thromboembolisms on my internal medicine service or rotation. And for them, we put them on clopidogrel right away, as well as rivaroxaban in a lot of them. Okay. And people use it when they're at risk for heart attacks and whatnot. So heparin is asking you, they're quizzing you. Good job, you guys. So its initial mechanism of action is that it increases antithrombin 3 activity. So it's increasing an antithrombotic molecule for that phase, and it makes it way more active. And then antithrombin is going to be deactivating thrombin. And then thrombin is involved with 2A and XA. I think thrombin is 2A actually, but it also goes up and activates XA or 10A. So pretty much the way that it works is it's leading to your common pathway being blocked, but it does that with antithrombin 3. And then the answer here is that delteparin. Does anybody remember the group that it's in?
That's low molecular weight heparin.
Yeah, so it's the low molecular weight heparin, which is kind of the newfangled heparin. That's not like the unfractionated heparin, where the unfractionated is the more old school one that's less consistent, less stable, and has to be monitored a lot more. There's more risk of overdoing it and leading to hemorrhage. So they're a little bit safer. All
Isn't
right.
it just heparin sodium that does both 10 and 2? Isn't the like low molecular weight, can't that only do, was it like 10 or?
Yeah, exactly. So your low molecular weight is going to be a little bit more specific. It's your unfractionated that's leading to XA and 2A. So I could see how maybe that might be a little bit confusing. I was just asking about like heparin in general. But yeah, really good point. So just kind of knowing those differences, those are kind of easy questions he could ask, especially about their safety and whatnot. And then for him, it's a good idea, the ones he underlines, to just be able to say, all right, delteparin, that's in this group. Okay. So this client's really quizzing you. Oh my gosh. Yeah, nice. Does anybody want to say what the mechanism of action of apixaban is?
Factor 10.
Yeah. So that's why this is my favorite drug name ever. I think I prefer rivaroxaban actually, but it's because it bans XA. So it bans 10A, factor 10A. So it's such a great name. They should name every drug like this. But it bans XA. And I always remember that since 10 is just X, it's where the pathways cross. So that's the beginning of the common pathway.
That is such an easier way to remember it than I was trying to remember.
Yeah, I actually came up with that this past year, the crossing part, but I think that's helpful. Whatever you can do, whenever I have a drug that I just keep forgetting over and over again, I sit down with it for a minute or two and I either pull it up in Plums and read a little bit extra to kind of like give myself a little bit more context to remember, or I try to come up with something dumb. So either like the dancing robot. So that's my advice. If you just keep forgetting a drug over and over again, which totally happens, like some of the antibiotics, just take a few minutes and say, okay, I'm going to read a little bit extra, and or I'll just go to the Wikipedia page or something. And also just kind of breaks up the studying a little bit. So you're just like doing a little bit less chugging off PowerPoint slides. Okay. This was the poster for that epileptic dog fundraiser. It says featuring free heartworm vaccinations. Good job, you guys. This is something totally clinically relevant. Some neurologists do give Keppra first, just because it's got a little bit less potential adverse effects. But our neurologists will tell you all the time that they really prefer phenobarbital because they feel it has better control. And that's something that he could definitely ask you on the test. Just kind of having in your mind the order of, all right, long-term control, status epilepticus, what comes first, what comes second? Those are just really easy questions for him. So one of these drugs doesn't act on GABA receptors. It's being bullied because of that. I could have given you more time. Oh boy. So this is one we're just kind of knowing your mechanisms. He wasn't as clear, but midazolam, propofol, and phenobarbital, all of those act on your GABA receptors. Does anybody remember if they're agonists or antagonists?
Agonists.
Yeah, so they're all agonists. So GABA receptors are ligand-gated ion channels. And when they get bound, they let chloride into the cell, which is negative, which further polarizes the cell. So they're going to be decreasing activity of neurons, decreasing brain activity. So it makes sense that midazolam, propofol, and phenobarbital are all doing that. Midazolam and propofol commonly for anesthetic usages, midazolam also for seizures, and phenobarbital for seizures. Where for seizures, you want to quiet down the brain because a seizure is an overactive brain. And then for anesthesia, you're decreasing brain activity, which is what is anesthesia? Ketamine, what's our mechanism of action?
NMDA receptors.
Okay.
Yeah, so it's going to bind to NMDA receptors. And does it agonize or antagonize?
Antagonize.
Antagonizes. So NMDA receptors are get bound normally by glutamate, which is an excitatory neurotransmitter. So ketamine is going to be binding them, antagonizing them, which leads to this dissociative state. And glutamate is also going to be a common neurotransmitter for pain. So ketamine, you guys will find out, is commonly used for pain control as well. And also for depression in people. Also for recreation in some people. Pretty dramatic photo. Nice. Good job, you guys. So according to Dr. Wagner, what's the most common use of clonazepam?
Isn't
And
it
it
a
was-
secondary choice for maintenance?
Yeah, it's secondary choice for maintenance in cats. I'm pretty sure the neurologists don't agree with that. Like I was talking to Dr. Barber this morning, actually, and she was like, we totally never use pentobarbital for status epilepticus anymore. But for this test, learn all that. And then next year, you'll learn in neurology some information that's slightly different. Completely different. But some of it's true, like phenobarbital. And in this case, most commonly what we use is midazolam in the ER at UGA. That's what we use almost all the time for seizures. In an animal that's at a seizure risk, we'll actually post the midazolam dose on their cage door, just so if they start seizing, you can grab it really quickly. Diazepam can also be used, but you can't give it intramuscularly. You have to give it IV, or you can use it IN. I don't know how it stacks up against midazolam, but yes. So just for Dr. Wagner's lecture, knowing what's your first line for maintenance in dogs, what's your first line and second line in cats, and what's your first line and second line for status epilepticus / what is status epilepticus. Just kind of having those ordered things. He's very explicit. Okay, this is something he just loves to bring up. So there's always a risk he'll ask you about it. And this pig had malignant hyperthermia, so it tried to run into the ocean to cool off.
Are you sure that's not just one of those pigs that lives in the Caribbean because a bunch of people brought them there and now they use tourists to get food?
They're just like horrifically degrading all the habitat. Nice, good job, you guys. That's really awesome that you guys have mastered the knowledge of this drug that you'll never use. Cool. That's just something he brought up, and he totally could use it. It's going to be blocking your ryanodine receptors, which are your intracellular receptors on your sarcoplasmic reticulum, and they're in charge of releasing calcium into the cell, which can lead to your hyperthermia. So it's blocking those ryanodine receptors and blocking that calcium influx. All right. This is your Overton-Meyer curve association thing. And they will bring this up in anesthesia again. This actually does have a little bit of clinical relevance. Believe it or not. Nice. Good job, you guys. So when an inhalant gas is more soluble, or more lipid soluble, it's very important to make that distinction. It can more potently act as an anesthetic, and it can act more quickly because it's spending less time being dissolved in your blood and hanging out there, and it just goes right straight into that neural tissue that you guys remember is full of lipids like myelin and whatnot. And it's able to go in there, and then it's able to go into the cell membrane and act with these transmembrane domains. All right, that's something he could ask you about because you made a decent point of it and spent a couple slides. Oh boy, I talked about this earlier. So I guess I'll find out if my teaching has gone on deaf ears. It's okay if you get it wrong.
Is it just me, or are the yellow and green options the same?
They are.
Oh no.
Okay. Yeah, I didn't answer because I was too confused.
So I forgot to change this one. Oh no.
Tragic. I put the yellow GABA.
I think I had a terrible question last year and I changed it last minute, and then I forgot to fix the answers. So you guys who did blue were right. It's NMDA, and it's inhibiting the NMDA receptors. I'm sorry for anybody that was unjustly punished for putting down the right answer.
Wait, I thought glutamate was excitatory, not inhibitory.
Oh shit. So glutamate is excitatory. I was thinking about ketamine, I think, when I said that, which is antagonizing. So glutamate, all right, we're starting from scratch. We're all confused. It's nobody's fault. But pretty much, glutamate is a neurotransmitter that binds to NMDA, and it is excitatory.
It's okay, Fred. We really appreciate you.
That was really big of Allison to correct somebody that she really respects. It takes a lot of guts.
Who said I respected you, Fred? You Fred? I'm kidding. I'm kidding.
All right.
Ooh.
So I guess I take that back. If you put blue, what were you thinking? All right. I guess there was no right answer available, so you did your best. Perfect. Oh no, my koala's sick. It needs an antibiotic. It's a hindgut fermenter, for those of you that don't know koala GI physiology. That's a picture of it. And there was some philosophy that goes into this question, so you have to really think about it. I don't know if you guys can hear that. My roommate's yelling at her cat.
What did the cat do?
It's been a hooligan recently. It's like tearing up our furniture and trying to run out the door. When we were doing I-131 on my patient, I was like, can we do this on my roommate's cat? It's been terrorizing me. But it wasn't medically indicated. Nice. Good on you guys. Sound morals, macrolides in our hindgut fermenters. Does anybody remember why those are contraindicated in our hindgut fermenters?
Dead bunny.
Yeah, exactly. So does anybody know how that goes about? Like what causes it? It's in our
So
horse.
like it almost like takes out the microflora of the hindgut.
Yeah, exactly. It can cause a really severe dysbiosis and colitis, which can be fatal. So in a hindgut fermenter, it's just not worth the risk. There were a couple other ones that she mentioned being contraindicated in our hindgut fermenters. So she made a big point of those, I would remember. But I don't remember them right now. But this is the most important one that she really made a big point of. All right. And that's crazy that one of you carries azithromycin on you at all times. That's commitment. Oh no, this is you guys, not me. All right. So does somebody want to say why metronidazole, we don't use it in our food production animals?
It's either restricted or not allowed. I can't remember.
Yeah, so it's not allowed in like our cattle and whatnot, some of our production animals. Chloramphenicol, definitely not allowed. That's quite illegal. Aminoglycosides, we are allowed to use those, of course, using the correct withdrawal times and everything. But metronidazole, chloramphenicol, those aren't allowed. Does anybody remember what the deal with enrofloxacin is? In production?
Wait, just
What was that?
like immunosuppressive for chloramphenicol?
Yeah, so that's part of the reason why chloramphenicol is not allowed to be used at all. Is just because the risk in humans is so severe that they don't even let you try to do withdrawal periods or anything. It's just banned. Metronidazole, I'm pretty sure is similar. I know there's some risk of seizures and whatnot. I'm not sure if that's the exact reason in people, but it's just that the risk of residues for people is high, so they just don't let you use it. Gentamicin, it's okay to use just with proper withdrawal. With enrofloxacin, that's another one Dr. Beasley talked to you guys about. It's not allowed in lactating cows. So all female cows over like 20 months or something are considered lactating cows, even if they're not like actually producing milk. So you're not allowed to use enrofloxacin in them. But they use enrofloxacin in meat producing, like beef cattle, a good bit, like Baytril. Nice. And that's nice of you guys to have sustainable measures, but I guess antibiotic free can be pretty controversial because it can increase animal suffering. All right, so there's only one more question. I forgot to tell you guys the prize. I forgot to mention at the beginning. But the prize is that I will make you lunch, and if you so choose, eat it with you. I've done this in the past. If that sounds like a punishment, I can just drop off lunch for you. And then the second place person, I'll get you a copy of the Plums app because I think it's so important, and I wish somebody had coerced me to get it my second year. All right, one more question. Let's see. This is a tough one. I don't actually know when you guys' next exam is. It could be like Wednesday or something. Whoa, good on the 7 of you guys that are contemplating your tendencies and values. I think that's really important to do, but you should probably just give yourself a break tomorrow after the exam. Do that another time though. Yeah, you guys, you've been working super hard. I know you guys have been taking a ton of tests, and it really can wear on you. There were definitely every single semester, I feel like there were times where I was really burned out and just kind of you can get fed up with it at times. It can wear you down. So totally just like take that day or a few days. I don't know when your next exam is, but make sure you're really like drawing some good boundaries and just having a clear mind for a few nights. It can be easy to be on to the next thing before you really kind of, no matter what happens tomorrow, you guys worked really hard, presumably, for this exam. So that's awesome. Like that's a really big effort to put in. And this stuff can be pretty dry and it's not everybody's favorite. So really sitting down with it for a long time is really admirable. Yeah, cool. I did want to tell you guys, Dr. Ubig's GI drug lecture, that's pretty much one of the biggest bang for your buck lectures in all of that school as far as stuff coming up again. You're going to use those drugs almost every single day on clinics. Every rotation where you have inpatients, general surgery, ortho, internal med, neuro, oncology, every single one, you're going to be using those. Like as a general practitioner, you're going to be using those all the time. And there's some nuances to those drugs, and knowing their mechanisms is important. And they'll come up all the time, and clinicians will ask you every rotation. Like the clinician was like, Dr. Barchis was quizzing us a ton on Serenia because someone said they wanted to give their patient it. And I was the only one who remembered that it's neurokinin 1 and substance P. And he was like, oh my God, you actually remembered that? So totally, it can be good to, that's a good lecture where if you're like, okay, this all feels useless, that's a good one where you can know it will be worthwhile to spend time on. All right. Let's see, who's the next Dr. Wagner? Haley, excellent job. Faith, awesome. See, this is great. Some of my Kahoots, it's like the top place person, it got like 20 out of 40. And it's like, oh my God, this Kahoot was terrible. Nice. So Ashley and Faith, if you guys reach out to me, we'll get you your prizes. Awesome. Well, I hope this was helpful for you guys. Definitely tried to focus on what was important. I know some of those antibiotic questions were kind of a mess, but she gave a really good study guide. Anything that's bolded or underlined in all caps on that study guide, definitely have down. Just knowing your mechanisms for the group, knowing any contraindications that she spent a decent amount of time on, like really emphasizing. If she made a big point about their activity, I would do my best to know